All right, let's go ahead and get started. Good morning, everyone. We have two great talks this morning. Our first is on wellness and professional development in surgical trainees. This will be presented by Dr. Kshama Jaiswal, who is an assistant professor in the Geitz Division based at Denver Health. By way of background, she did her undergraduate training at Southern Methodist University, did her medical school and general surgery training at UT Southwest, and then did the Rosenberg Surgical Oncology Fellowship at the NCI, and was actually on faculty for a year. I don't know if you call it faculty, but you were a staff surgeon for a year. And then went to do the Breast Surgical Oncology Fellowship at Memorial Sloan Kettering Cancer Center. We were extremely lucky to recruit her to our programs here in Denver and in Colorado. As I think all of the trainees know and the faculty know, she is extremely involved with the educational programs here at the University of Colorado, both at the resident as well as medical student levels. She really is a very busy clinical surgeon and runs the breast program at Denver Health, very respected, and she's really doing some groundbreaking work and leadership in this relatively new area of, believe it or not, wellness and centeredness and career growth in surgery. And we really look forward to your talk this morning on this topic. Thank you.
Thank you so much for the privilege of this podium. It was not discussed when I was a resident. So I have 4 objectives for today, besides getting the talk working. Okay, great. So my 4 objectives for today are to define wellness as relative to burnout, talk about the epidemiology and the scope of this problem, and discuss why we should care, why should we try to fix this problem, and then some ideas about how we could try to fix this problem. So first, definitions. So wellness could be thought of as a balance between negative inputs and positive inputs. If we want to improve wellness, we want to have fewer negative inputs, meaning less depression, less emotional exhaustion, less depersonalization, less distress, and more positive inputs, finding more meaning at work or at home, finding a balance of physical, emotional, and spiritual health, and finding more satisfaction at home and at work. And if we have more positive inputs, fewer negative inputs, we can maybe improve wellness. But should we aim for a balance? We hear a lot about work-life balance. Should we aim for a balance of these positive and negative inputs? Or should we aim for something more? I would argue that we should aim for something more. This is a quote from Tate Shanafelt, who incidentally was a former CU medical student and is now a medical oncologist at Stanford and is a leader in this field of research. He says that well-being goes beyond the absence of burnout or depression and includes being challenged, thriving, and achieving quality of life in mental, physical, emotional, social, and spiritual domains. I agree with Dr. Shanafelt. When it comes to burnout, it's maybe an imbalance of these positive and negative inputs. Maybe it's having more negative input than positive. When you look at the literature and the studies of burnout, it often uses this survey tool called the Maslow Burnout Inventory, which is a 22-questionnaire survey that has these 3 domains. And so the recipe for burnout in the literature is having increased depersonalization, increased emotional exhaustion, and less personal achievement. Thankfully, there's a 2-question version of this larger questionnaire, and that has been validated in physicians. And we have used this questionnaire in the survey of our residents that I'll show you in a little bit. The 2 questions that we ask are, I feel burned out from my work, and I have become more callous towards people since I took this job. And it gauges a frequency of how often these feelings occur between 0 to 6. 4, 5, and 6, once a week or more of having these feelings is considered being burned out on one scale or the other. So those are some definitions. Let's talk about epidemiology. So this is a graph of physicians in practice in general. This study looked at burnout on the x-axis and percent satisfaction of work-life balance on the y-axis, and looked at this in both 2011 and in 2014. And we could see that the study showed that 54% had at least one symptom of burnout in 2014, and that's this dotted line here. And 41% of physicians were satisfied with their work-life balance, which is this horizontal dotted line there. And if this were a job fair, I don't know that we could recruit a whole lot of people by saying, hey, come join medicine. You have 50% chance of being burned out and maybe about 40% chance of being happy with your work-life balance. So let's look at some of the specifics. You know, emergency medicine colleagues over here are quite burned out, even though they may perceive they have a better work-life balance. Our poor urology colleagues are both burned out and don't really have as much satisfaction with their work-life balance. And our neurosurgeons, while they may be less burned out than average, really pretty much just laugh at the concept of work-life balance. And in terms of general surgery and general surgery subspecialties, we're about average on both of those measures. And somehow the folks in occupational medicine and preventive medicine have figured out how to be less burned out and have a better work-life balance than the most of us. So that was surgeons in practice. What about surgery residents? There are two big studies that looked at surgery residents. In 2014, 665 residents responded to this survey, and 69% of them met criteria for burnout. There was a difference between men and women, where women had 73% rate of burnout and men had 65%. 44% of these residents considered dropping out of surgery. And 44% they just wouldn't do general surgery. They would pursue, and 40% said they would do careers outside of medicine completely. In 2016, a similar survey was done in residents, and again, still found the same 69% rate of burnout. They didn't find any gender differences at this point, but they did note that the PGY2 year had a higher rate of burnout compared to other years. So that's some about the epidemiology. Now, next question is, well, why should we care about this, and why should we try to fix the problem? I would hypothesize that this affects many different levels. It affects our healthcare system, it clearly affects physician health, and it affects patient care as well. So let's talk about each one of these individually. With regard to the healthcare system, if one is burned out, there's an increased likelihood by 67% of decreasing FTE work effort. And if you take this statistic and put it across the United States, that's equivalent to losing 7 medical school graduating classes. In this particular survey done in 2012, 2% of physicians said they would leave medicine altogether. That's outside of retirement. And that this rate was higher for mid-career physicians. And losing a physician is a cost to the system by losing patient access and the cost to replace them. So an organizational cost to replace one physician is estimated to be between $500,000 and $1 million. And clearly, burnout affects physician health. Surgeons have a fairly high rate of substance abuse and dependence. In this survey of American College of Surgeons showed that 16% of practicing surgeons have abuse or dependence of substances. In surgery residents, it's nearly twice that. 33% of residents met criteria for substance abuse or dependence. And in terms of suicide, physicians in general are at higher risk than the general population. Men are at 1.4 times higher risk than the general population, and women are at 2.3 times the risk of committing suicide if they're a physician. Another American College of Surgeons survey suggested that 6% of practicing surgeons have had suicidal ideations within the last 24 months. And surgery residents are nearly double that, 11%, and relative to the general population, it's about 3%. Every year, about 300 to 400 physicians are estimated to commit suicide. This clearly affects patient care. With regard to surgeons, a surgeon who is burned out has a higher associated rate of self-reported errors. And a surgeon has an odds ratio of 3.2 of self-reported errors if they meet the criteria of depression. Malpractice suits are also associated with folks with burnout. And in this particular study done in Europe, where patients and physicians were paired in dyads, showed that if a physician was burned out, the patient perceived lower satisfaction and they perceived a longer recovery time. So all of these studies, one could argue, what came first? Did the burnout come first? Did the poor patient care or the medical error or the malpractice come first? These studies don't really go into that, and you can't tell. All we know is that there is definitely an association between burnout and these problems. So hopefully I've given you some food to think about, and hopefully I've begun to have you think that this is a significant problem in medicine and in surgery. So what about how do we fix this problem? And I completely agree that the problem of burnout has many facets and many fixes. And one of these is fixing the systemic problems in our healthcare systems. Electronic medical records, frustrations in OR scheduling, inefficiencies of the OR, I think definitely contribute to burnout. I'm not going to talk about those here. That would be another 30-minute talk altogether. But I think an interesting way of looking at how to fix this problem of burnout comes from the psychology literature. This is probably familiar to many of you, and this is Maslow's hierarchy of needs. Maslow was a psychologist who in 1943 theorized that humans have 5 fundamental levels of desires and needs. At the base is physiologic needs, then safety, love and belonging, esteem, and self-actualization. And when Maslow first came up with this, he thought that meeting the base physiologic needs were important and needed before meeting some of the other needs. When we think about this and rethink it in terms of education, we think about it more in a pie, more in a circle, because all of these needs are thought to exist simultaneously, hence the circle. So if we go over each of these, in terms of a resident, in terms of physiologic needs, and a resident has needs for eating, for sleeping, being hydrated, going to the bathroom, the real basics. Level 2, safety, meaning is this person physically safe? And also, with regard to a resident, are they financially safe? Do they have a job next year? Love and belonging. This means, does the trainee have time for community, for family, for time for reflection? The next pie, esteem. I think this esteem pie is a huge problem in training because in training, fairness and control of schedules are often not at the control of the resident. And finally, self-actualization for a trainee would mean having mentorship, having career planning, and looking towards the future. I'd like to talk about a program that we have developed at Denver Health that addresses pretty much every single piece of that pie. Dr. Barry Platnick, who's here with us today, is an acute care surgeon at Denver Health who developed a weekly wellness and professional development conference for residents, affectionately dubbed Muffins and Meditation, or sometimes Breakfast with Barry, usually some form of foods available. And in this 1-hour conference, Dr. Platnick starts out each meeting by reviewing these principles denoted by the word TRANS. TRANS stands for tolerance, respect, anonymity, non-retaliation, compassion, and egalitarianism. And with a review of these principles, he's able to create a safe and confidential environment. After that, Dr. Platnick leads a 10-minute mindful meditation, which is silent, and it's a practice of drawing one's attention to a single focus, and then recognizing the distractions that come during that time and ushering away those distractions and returning one's attention to a single focus. The next 40 minutes of that conference are used in a facilitated discussion of a variety of topics. Two basic categories of topics are chosen, either a professional development topic or a personal or professional wellness topic. These are some of the topics that have been discussed, including things like negotiating contracts. What is a medical staff structure? What does peer review mean? What is credentialing? What are the different types of practice settings that are out there? And he also talks about burnout. What are the effects on a physician of adverse outcomes, of complications, of morbidities and mortalities? He also talks about substance abuse and depression and suicide. After about a year of having this wellness conference, we evaluated it in June of 2018. We asked the two-question burnout index that I talked about earlier. We also surveyed for mindfulness and also examined positive and negative affects and examined self-compassion. So these are our results. We had a good response rate. 77% of residents responded. 61% were male. 59 were in a committed relationship. 75 were categorical residents, and we had a large number of junior residents in the respondents. 83% reported that they had attended at least one conference, meaning 17% had never attended a single one. In terms of our results, we found that mindfulness and self-compassion didn't really change based on conference attendance or not. At baseline, males tended to have more self-compassion than females. In terms of burnout, 41% of our residents met the criteria for burnout on one or both of those scales. We didn't find any difference between men and women. We did find that burnout decreased the further along in training that a resident was. Our intern level of burnout was 59%. We found that burnout decreased as residents attended more meetings, and there was a trend, though not statistically significant. You can see in this graph that residents who had never attended the conference had a 57% rate of burnout versus those who had attended 7 to 9 meetings had a 25% rate of burnout. We did also find that the further out that a resident was from the last time they attended the conference, the more depersonalized and more callous they became, and this was statistically significant. We found out that burnout was associated with more negative affect and lower self-compassion. So we concluded that this weekly wellness and professional development conference can help mitigate some of the effects of burnout. But we didn't want to just look at burnout. We wanted to look at flourishing. Flourishing encompasses both feeling good and doing good. And the flourishing index is a ratio of the positive and negative emotions. A ratio of greater than 2.9 is described as flourishing, sort of in the green zone. And a ratio that falls between 1 and 2.9 is considered languishing. Our residents are in the languishing zone. Thankfully, there weren't any residents who were in the under 1.0 zone, in the red zone. We did also find that older age and that the closer that a resident was to having attended the last conference was associated with a higher flourishing ratio. So besides this wellness and professional development conference, what else can we do for our residents to help them flourish? We hosted a retreat in this last October in Estes Park. We took research residents and PGY3 residents. 9 residents total were able to attend. We had 3 surgical faculty, myself, Dr. Platnick, and Dr. Kanzen, and 5 non-surgical faculty, a pediatrician, a psychiatrist, 2 family practitioners, and an internist. We had a structured agenda, which included going over the communication course that's put together by the Institute of Healthcare for Excellence, which I think many of you are familiar with, and that I teach at Denver Health as well. We also went over the CU Flourish modules, finding one's values, and an introduction to total well-being. Of course, there was outdoor activity involved as well as art, and of course, lots of food. These are some of the objectives that the residents came up with. And since our residents are overachievers, there wasn't just 2 or 3 objectives that they wanted to accomplish in those 48 hours. There were 14 objectives that they wanted to get through. They wanted to vent and share. They wanted to get to know people better. They wanted to find tools on managing stress and prepare for their future careers. They wanted to take a minute to relax and breathe and hit a bullseye during archery. And they wanted to develop healthier habits that humanize the profession. Importantly, they wanted to change culture. They wanted to remain compassionate, wanted to find some tools on how to manage up. They wanted to regain a sense of themselves and wanted some tools on how to overcome preconceived notions. They wanted some healthy ways to process criticism and how to manage their own expectations better. For the last few minutes, I'm going to focus on this objective here, changing culture, because I think in changing culture, we really have the opportunity to move the needle towards the positive. So the next few slides, I'm going to make some suggestions about how we can change our culture to become a little more positive, and they're totally my opinions. You may disagree. But here are some things that maybe faculty can do to help. In the current situation, I see this not infrequently, that a resident evaluation says that they have poor operative skills, maybe they're behind their peers. Maybe we could change that and we could be more formative in our evaluations. For example, I've told a resident that, you totally understood what we were trying to resect, but it didn't turn out smoothly. You were fulgurating with the bovie, and I think smoother motions with your bovie would make things go a lot better in the OR. I really think residents crave these formative evaluations. Currently, it seems that residents are often asked to be in more than one place at a time. They're asked to be in conference. They're asked to make sure that the patient in the OR is pre-opt appropriately. They're asked to be the first in clinic. And I think sometimes attendings could help this stress by being more globally aware of the multiple responsibilities that our resident team has as a whole, and maybe even help prioritize. For example, if the first case in the OR is a sebaceous cyst, maybe the resident really does need to be in conference, and the sebaceous cyst can be done by the attending surgeon alone. Sometimes a resident who does a majority of the work on a project is not necessarily the first author. And I think this goes back to the pie that talked about esteem and fairness. I think authorship discussions probably need to happen openly and early and often, and need to be consistent with the degree of contribution. Well, what can residents do to help themselves? Sometimes I see this. I see a resident who perhaps has a light day and maybe is in their own bubble and hangs out in the call room while there are other residents on other teams who are struggling with a heavy clinic or inpatient service. And then maybe instead of being in that bubble, it would be great to be able to help your fellow residents and to step out of that bubble a little bit. I have no doubt that this resident class would step up in a crisis. If we have a missing resident, we have a sick family member, I know this resident class would help step up in that crisis moment. I do think that stepping up on a daily basis would help change our culture. Sometimes it seems that residents and medical students wait to be spoon-fed their education. I think residents would find a great deal more meaning in their work if they were able to take control of their education, maybe make some goals for each rotation and seek to meet them. I think residents avoid making appointments with their primary care doctors, their psychiatrists, or their dentists, and if they do make those appointments, they feel guilty for going. I would advocate that the residents do schedule those appointments and notify their chief residents and attendings that those appointments have been made and arrange coverage in advance if possible. So what can we all do to help change and improve our culture to be a little bit more positive? I'm totally guilty of this, and I have to work on not coming to work when I shouldn't. If I have a fever, if I'm throwing up, if I need IV fluids. I think it's as soon as last month that I heard of someone who came in, got an IV fluid bolus, and continued to round after that. And maybe the better thing to do would be to actually just stay home. Disparaging other specialties. I hear this from both residents and faculty. I think this propagates negativity, and I think that instead we ought to recognize and respect what each specialty brings to the table and realize that even at the intern level, juniors are watching, medical students are learning from us, and that they are emulating what we are doing. It seems in surgery that self-deprivation is a sign of strength. Doing an all-day case without taking a break for water in or water out seems to be a sign of strength, and I would advocate that maybe we need to recognize our own human limitations and needs. My hope is that over time, with maybe a little bit of change in culture and maybe an increase in the options that we have for our wellness curriculum, I'm hopeful that we can move our score from languishing up to the flourishing level. And to remember that flourishing encompasses both feeling good and doing good. Thank you.
We have plenty of time for comments and discussion. How about from the trainees? Anything? Yes, go ahead.
Thank you, Dr. Jaiswal, for your efforts in this program, and I can tell you the trainees all are appreciating.
Speak a little louder, we can't.
Thank you for all of your efforts, Dr. Jaiswal, in developing this program, and Dr. Platnick as well. I can tell you all the trainees are greatly appreciative and enjoying kind of working through this process with you and looking forward to seeing what the future brings. I thought it was particularly striking to me that the suicidal ideation in trainees was up to 11% when we have 10 trainees a year, categorical trainees each year. Can you give us a little bit of advice on helping to recognize trainees that might be struggling and how to approach them and what resources might be available?
The question was, how do you recognize fellow trainees who are struggling with suicidal ideation?
That's a great question. It's as if I planted you there. So, so there's a GME has come up with a resident mental health clinic that's open 24/7. There are options available for urgent and non-urgent visits that residents can access. I think that when residents, when you notice a resident that is isolated, maybe doesn't associate with other residents, I think those can be signs that someone may need a little bit of help. And these are free and confidential resources for a resident.
And, I hope you also feel comfortable enough to contact Dr. Naylor and say, hey, I noticed this going on. What do you think we should do? I think Mark is the most accessible program director in the country. And I see he's texting everyone about sports scores all the time, as well as residency training issues. So I hope you feel comfortable doing that. And I hope you feel comfortable communicating with me, too. And, these are uncomfortable conversations, but if it means saving somebody or making somebody's life better, we just need to do it. And Mark.
Well, I think one thing that helps probably morale as much as anything is you're not going to solve all the problems, but it's the legitimate sort of, desire to do so. It's sort of like you're taking care of your patients, we're all going to die. Everybody in the room's going to die. Hopefully not today, but it's happening. And so it's like compassion and what can you do to help people get through life with the best outcome possible, et cetera, et cetera. We have lots of patients with bad issues, and how can we make it best? Healthcare has a lot of issues, a lot of sort of no-win situations you get put into, and how can we make it so that you at least feel heard and you feel like we're trying to do the best we can. We're not going to be able to solve every last problem tomorrow, and a lot of this stuff might take several years. And some of it, we might only be able to solve a small percentage of it. But I think it's more or less the feeling that people, sometimes when people come to my office, we have a long conversation, they feel better, but it's not like we did a whole lot. We didn't come out with like 12 action items, other than next time they feel like that, they're going to come in the office and we're going to have that conversation again. So I think it's things like that are important. And then sort of the retreat and the things that you're doing, and looking at how we're doing and following our data as well, which is one of the things that you're starting to do. But it's too complicated to have like an obvious solution for everything.
And these activities that are being described take things to the next level, which is extremely important. But just to give you my 3 cents of what I've tried to do throughout my whole career, starting from college, medical school, all the way through, is there are really three important areas that, I've been burnt out at several points in my career, but there are really three things that I've done that I think have really helped me. One is keeping my friends, family, and mentors close, i.e., I talk to them. When I'm in trouble, I ask for advice, and I do the same for them. It's extremely important. Number two is exercise. Exercise can go a very, very long way. And the third thing, which I think we're all horrible at, is to have outside interests away from medicine. And, it gets harder as you get older, actually. And so, you're busy as trainees. You don't have time for outside interests. But you need to pick one or two hobbies and heavily invest in them, whatever it is, whether it's another language or collecting something or, who knows what. You must have outside interests, and you must invest in those outside interests. Otherwise, you'll become unidimensional. So those are three relatively straightforward things, but they're very powerful. Barry, you had a question or a comment?
I just wanted to make a comment. When we're talking about sort of solutions, I think this is the beginning of the solution. The beginning of the solution is intentional dialogue. It's actually having a conversation. And, you saw the trance slide. I think we as faculty, and actually you as residents, we need to learn to create a safe environment to have the conversation. If we feel like we are being weenies or whatever it is by bringing this stuff up, it's not going to happen. You're not going to recognize somebody is struggling unless they feel safe or comfortable talking to you about that. And so I think that the first step, if you look at the slide that had where the residents put up their goals for the retreat, or if you look at the trance slide, which speaks to principles around creating a safe space, a lot of what they wanted to do is get to know each other better, vent, share, remain compassionate, relax and breathe. I mean, we all know what to do. We just need to create the environment to have it, to be able to do it. And so I think that's part of our job as faculty, is to work on creating that environment. The other thing I wanted to do, and this is just for brief kicks, I'm going to do a single blind study. Just so I'll look this way. How many people have been to the Wednesday conference? How many people appreciate it, enjoyed it, or found it valuable? Okay, so I didn't look, I didn't see, but I don't, there's the statistics, and then there's the, then there's the truth. And so I think it's good. I think we need to work on creating these environments and working with the residents to bring this into the light.
Right. Awesome presentation. Thank you very much. Thank you.